Welcome everyone. Thank you so much for joining us this evening. Welcome to our UK Med event, What's Next? The Future of Outbreak Response. So my name's Holly Smith. I'm UK Med's Head of Fundraising and I'm here to welcome you to the event before I hand over to our chair and panellists. Thank you so much for joining us this evening. Just a little housekeeping before we kick off the main event. We really want this to be a discussion this evening. We want you to join in. So we're encouraging you to get involved with the conversation. You can use the chat function at the bottom of your screen to introduce yourselves and network with other attendees. And then there's the Q&A function to put your questions to the panel. We'd also love for you to share about our event or tweet on social media. So we'll be posting links in the chat function so that you can follow us on those various social media channels. We'd also like to see who's here with us in the room and who's been able to join us this evening. So I'm going to pop in front of you all a poll and just ask you to let us know what's your link to UK Med. So I'll give you a little bit of time to fill in this poll now. Thank you, everyone. It's moving in real time. It's very impressive. Thanks, Hilary. Nice that you can join us. Fantastic. I'll just give it a couple more minutes, moments before we end that poll. Fabulous, thank you. So we've got a lot of UK Med members here. Thank you so much for joining us. And we've got some partners, some NGO representatives, some representatives from different agencies. We've got some academics in the room as well, and some donors and clinicians. So thank you so much for joining us. You're all very welcome. So we've got lots of different insights in the audience, which is great. But I will speak no longer and I will hand you over to the chair of our event, Sarah Collis, who will introduce our panel and the format for the event. Thank you.
Thanks, Holly. Hi, everyone. My name's Sarah Collis. I'm the Senior Health Advisor for UK Med and the health lead for the UK Emergency Medical Team's COVID-19 response in the Rohingya camps in Cox's Bazar. We've got a fantastic panel for you this evening, and I'm confident they're going to bring a very fascinating perspective on the future of outbreak response. And we're especially delighted that our guest panelist, Professor David Heymann, has been able to join us tonight. I'll be introducing each panelist one at a time, who will share their opening thoughts to the question, what have we learned from COVID-19 and what's next for outbreak response? We'll have plenty of time for questions and discussion after these opening statements. And once we've heard from our panelists, it will be over to you, our audience. So please do add your questions in the question and answer section and feel free to add any of your own comments in the chat function. But first, I'd like to share some of my own opening thoughts as the Senior Health Advisor for Outbreak Response within UK Med, and especially as someone who has recently returned from the COVID-19 response in Bangladesh. For myself and my colleagues, COVID-19 has highlighted more than ever the need for a flexible standby capacity, which can be accessed and activated quickly when there's a need for technical support or frontline clinical care. We as an organisation and as a sector need to continue to invest in these teams and in preparedness as a whole. We've understood, perhaps more than ever, that building partnerships with international and national organisations and structures is vital in allowing our teams to use resources effectively and quickly embed into these responses. And we've once again seen the importance of academic partnering for mutually beneficial real-time information sharing between frontline responders and ongoing research or modelling, and not to mention the after-action learning on how to improve future responses to outbreaks. Perhaps most importantly, COVID-19 has reminded me of the absolute necessity of building national capacities, whether that be emergency medical teams or individuals. And when I think of what's next for outbreak response, I truly hope programming and funding for preparedness and recovery, not just response, especially for national capabilities and NGOs, becomes the norm. So on that note, I will pass to the first panelist, and it gives me great pleasure to introduce Professor David Heymann. Many of you will know Professor David Heymann, but I will just give you a brief introduction. David is a Professor of Infectious Disease Epidemiology at the London School of Hygiene, Tropical Medicine, and is the former head of the Centre of Global Health Security at Chatham House. Previously, he was the World Health Organization's Assistant Director General for Health Security and Environment, and from 1998 to 2003, he was the Executive Director of the WHO Communicable Diseases Cluster, during which he headed the global response to SARS. Prior to that, he was the Director for the WHO Programme for Emerging and Other Communicable Diseases. David, over to you. Thank you.
Thanks very much, Sarah, for that kind introduction. And you talked about the SARS outbreak, and really things began to change after the SARS outbreak. You know, at that time, there was in place a set of regulations called the International Health Regulations that tried to stop disease at borders by requiring vaccination for yellow fever or other activities. But it was learned in SARS that borders really don't stop infectious diseases. We knew that as technical people. The politicians didn't know that. But that was enough for them to get interested in revising this treaty, the International Health Regulations. And instead of trying to stop disease at border, the emphasis became trying to help countries establish the capacity to detect and respond to disease when and where they occur, so they won't spread internationally. And that led to a whole new thinking of, let's not build global capacity to respond, let's build national capacity, as you said earlier, Sarah. And so that's the way that things are moving forward at present. And shortly after the Ebola outbreaks in West Africa, I attended a meeting of MSF where they were struggling to decide whether they would change their outbreak response into technical capacity strengthening and core capacity and public health strengthening, and begin to develop capacities rather than respond. They decided not to change, and they continue to respond mostly to outbreaks and to disease issues and build up their own infrastructures within countries. But the trend today is to build up capacity in countries, and we've seen why that's so important in COVID, where the countries that have been able to respond, to detect and respond rapidly, especially in Asia, have been able to control the outbreaks in countries such as Vietnam, Singapore, whereas countries, including our own, have not been able to detect rapidly or didn't analyze that data rapidly, and therefore the outbreak was well established by the time they started. So the debate still exists, what's more important, national capacity or a global response to do the job for and with countries when they have to. Thanks very much, Sarah.
Thank you, David, and I'm sure we'll be coming back to you with some questions around that. So next we're going to move on to Amelia Hornsey. Amelia is the Senior Infection Prevention Control Nurse for the UK Public Health Rapid Support Team, which is a collaboration between Public Health England and the London School of Hygiene Tropical Medicine. Amelia has been a member of the UK EMT since 2016 and has worked in outbreak response since 2014, initially as part of the West African Ebola response, and then in a variety of domestic and overseas settings since then. So Amelia, thanks very much for joining us. Over to you.
Thank you very much for the introduction, Sarah. Pleasure to be with you all this evening. I'm going to talk just for a few minutes now about the role of remote support. I think the present pandemic has forced us all to adapt our ways of working. And I'm going to talk about my experience of working with AFCOR, the African Task Force for Coronavirus, and pick out a few lessons identified. Caveat, of course, this is my perspective, and I don't know if my colleagues are going to agree with my my interpretation of it, but just give you a tiny bit of background. So the Africa Union set up AFCOR with heads of member states on the 22nd of Feb, and that's the continental mechanism for coordinating the public health response to COVID. Had really good buy-in from heads of state, and engagement's been consistent. We've also had inspirational leadership from John and Kengasong at Africa CDC, so really strong base for that. And AFCOR has set up pillars very similar to an IMS system, which we're probably all familiar with: surveillance, lab, community engagement, science innovation, case management, and IPC. And then the IPC technical working group has had specialist groups that have focused on research, logistics, guidelines, and training. So these are all multi-agency groups, and they've got representation from WHO, AFRO, and EMRO, non-profits like Resolve to Save Lives, academic institutions, and other AU bodies. So they're quite collaborative and a good mix. And the sort of activities we've been involved with have been anticipating and responding to requests from member states, and horizon scanning. So for example, say for guidelines, we focused on really contextualizing international evidence to continent-specific issues. So looking at mitigations for shortages of PPE, or human disinfection with advisory notes against human disinfectants with sprayers, etc. So I started out working with AFCOR in February, 3 weeks in Addis Ababa, and then there was concern about borders shutting. So I've continued working remotely since then from London. And I just wanted to pick out a few reflections. There's been I'd say a huge number of unexpected benefits. I think the pandemic has changed expectations about how we work, and people don't necessarily expect you to be in the same room now to work together effectively. Our tools have improved for remote working. Video conferencing is a lot better. And actually some of our African partners like Infection Control Africa Network have been well ahead of the curve. They've been delivering continent-wide training on Zoom since 2016. I didn't know what Zoom was then, they had to explain it. So it's really been good for these strategic regional bodies. So, because we're often working remotely from each other anyway. So it's been quite a sort of beneficial learning experience. Another pro, it's instant, no waiting for visas or flights, and potentially it can reach areas where transport, security or political issues might make it difficult to deploy in person. But there are some limitations or challenges that we've had to work through. So one, of course, is time zones. I'm very sort of simple working with Africa due south, but I know for colleagues who are supporting Bangladesh remotely, they've been waking up in the middle of the night to get onto meetings. And you really need to put some emphasis into building trust and relationships, understanding context on the ground, but it's facilitated this longer period of engagement, which I think has been productive. So it does work better, this remote deployment, if you know your colleagues beforehand, I think, or if you've got a key on the ground liaison person. You can't really expect to jump straight into it. But I think that's actually the same for in-person deployments. I think we're sometimes over-ambitious about the groundwork that you need to do when you first get into country. And I've been very lucky to be embedded in a really young, dynamic institution that's very sort of solution-oriented. So it's been great. Obviously, the limitations of unreliable internet we're all familiar with, and telephone networks, but notwithstanding that, I think it's been a really positive experience. There's also a lot of evidence around telemedicine and telehealth from other settings that I think we can draw on for the future. There are some legal and technical challenges around that, but I think there's definite value in looking into those as options. So quick conclusion, I think, remote support is definitely not a replacement for in-person deployments, but I really do think it's another string to the bow. And I think really embracing it as an option can broaden both the places that we work with, and also I think critically it broadens the number of people who are able to engage in this sort of work, are able to provide support, because not many people can drop all their home commitments and jump on a plane and go and live in a tent for a few weeks. And we actually narrow the pool of skills that we are able to draw on by making that an essential part of how we deploy. So it's not just technical skills, but there are going to be a lot of language skills, and also getting a representative mix of ages, genders, and racial representation within these sort of units. So the EMT and the RST, I'm speaking for across both groups there. I think remote deployment has benefits both for our collaborators in the field and also for us as institutions for the future. That's it from me. Thank you very much.
Thanks so much, Emilio. I definitely relate quite a lot of what you've just said, and I'm sure there'll be a lot of questions around that. Just to remind everyone, there is a question and answer function. If you want to start writing your questions as we go along, that will mean that I'm ready to spring them on our panelists as soon as you've put them in there. So we're going to go next to Ngoni. So Ngoni is our team lead for the UK Emergency Medical Team response in Zambia. Ngoni's expertise lies in coordination, logistics, and risk communication, community engagement. Before working with us, he had responded to outbreaks in Ethiopia, Iraq, South Sudan, Yemen, Zimbabwe, and the Ebola outbreak in Liberia. So I'm hoping that Ngoni's connection problems, were sorted because he's joined us from Zambia. Are you there, Ngoni?
Yes, I'm there. Thank you very much. Hello, everyone. Thank you for the introduction, Sarah. I'm going to be looking at the response in Zambia. As UK EMT, we joined the Zambia response in March, and there are a number of issues that I have noticed, and I think they are very much important whenever we're doing any emergency response efforts, health emergency specific, and as we move forward, I think also we picked up some lessons learned, which in my view, we can actually discuss to say, okay, going forward, how can we continue improving the emergency response efforts globally? In terms of the Zambia context, basically the emergency was declared in March, and already the preparedness efforts throughout all the structures, both the government and the partners, where there's significant efforts were done to make sure each and every pillar is covered and all the relevant SOPs and guidelines that are in place, considering also that the emergency had already reached other countries before Zambia. So, but there are a couple of things that I have noticed. Issues around coordination is very key whenever we're talking of any response effort, because without proper coordination, definitely we are talking of either the response reaches the most needy communities late, or we can actually lose lives. So coordination, I've seen it to be very important, and it was very much prioritized in Zambia to the extent that there was a clear coordination structure through the incident management system that was created at national level, at provincial level, and at district level. So the emergency operation centers were established, making sure that all the 6 pillars that were established were created, are functional at all levels. I have noticed that the establishment of the incident management system is very critical and needs to be prioritized so that any response effort are not late, and it makes very easy for any other partner or any such capacity that is coming in country to easily fit and see how they can actually respond accordingly to the different pillars that they'll be looking at. And the coordination across all pillars is also something that is very critical. And in the Zambia context, at national level, the incident management system was meeting twice a week to make sure everyone reports on the ongoing efforts, which really made it easy for anyone to track where the emergency was and how to keep on improving on any other areas that needed agent support and attention. So I have noticed coordination is very important, and timely capacity building of frontline responders at all levels is something that is very critical. Development of FOPs, considering that the COVID context was changing over time, making sure that relevant reviews were done, and this has been done well in the Zambia context, and it's something that I have noticed. It doesn't only need to be done at national level to make sure the national structure knows all the expected SOPs and guidelines, but the dissemination to the last person who is reaching into the community, it's something that is very important. And whilst it was done a bit late in the Zambia context, we managed to make sure all the SOPs that were developed were disseminated to all the provinces, all the districts. And as the disease went into community transmission, we made sure all the communities had all the information in time. So capacity building also of all the structures in terms of standardizing the standard operating procedures and guidelines, I've noticed it's something that is very important. Also learning from the previous emergencies like the Ebola. Then I have noticed operationalization of projects. It's something that is very key, timely, and to make sure there are no bottlenecks. Most of the emergencies, the challenge is there are no waivers whenever there is an emergency on processes, on operationalization of any activity that needs to be done. So I have realized some of the projects that needed to be done would even get delays of up to 2 to 3 months, which meant that the services would reach the people a bit late. So operationalization, absence of waivers, it's in the context of COVID, definitely results in absence of agency to respond in time. Issues around supply chain and chain management, you realize some of the materials are arriving in country, probably from China or South Africa, 2 months down the line, 3 months down the line. That would definitely mean we are not responding in time. So there is need for systems to be waived whenever there are emergencies like the COVID, which really helps in terms of making sure we do not create bottlenecks in the response effort. In the Zambia context, I have also noticed that data, like any other emergency, is something that is very critical. A culture of open data, it's something that needs to be prioritized whenever we are having any response efforts. Data should be collected, processed, and actually shared at national level, subnational level, to all partners, and all partners need to access data, because the moment we have an open data approach, it enables evidence-based programming and making sure the future planning for any future programming, resource mobilization is made easy. And data generated in the response needs to be available to all partners in time. And this is still work in progress. And whilst a lot of partners have also put a lot of resources in terms of making sure data is availed, we have noticed that during the response, there were a number of gaps that we are actually in the process of supporting to ratify. Then another aspect that I have noticed is the epidemic response, human resource for health, which needs to meet global standards to appropriately plan for the response. Whilst definitely the frontline planners are people from in-country who actually know the context, there's also need for such capacity so that they also bring in other experiences from other responses, efforts like the Ebola and other global health emergencies. So I've realized that mix, there were efforts to make sure that it's there, but making sure that whenever we have frontline responders who do not have that international exposure, proper capacity building is done in time. And these, if they do the planning in time, that would mean deliveries and policies, they're actually developed and disseminated, and actions are done accordingly as the expected standards. So in terms of the main issues that I wanted to raise, I wanted to look at the issues around the coordination of the national, subnational, and local level structures, capacity building, and making sure that dissemination of SOPs and guidelines, they are done in time and coordinated at low levels, and making sure that operationalization of all the projects is done, not in a reactionary manner, but making sure that the system enables to be in an emergency mode and we deliver in time. We make sure all the needed supplies, they are there in time, and making sure that we have a culture of open data and across all levels, whether it's within the government or partner, and partners should be able to access all the generated data at any time so that they are also able to mobilize more resources, and also making sure that the epidemic, the human resource for health meets the global standards, and they also have the correct mix in terms of making sure appropriate planning for the response is done. Going forward, I think basically there is that need both for partners and the government to make sure these waivers are in place, to make sure that there is transparency in the data that is generated in the response, and making sure that the devolution of the response effort, the response is not only focused at the national level, capacity building the national structures. In Zambia, it was a bit late in terms of evolving down to the district level, to the extent that sometimes it had to take the effort of the national structure to make sure they reach out to each and every district. But at the moment, all the structures, they are engaged at the beginning of the response. It actually makes the response effort on the last person, the last mile, to be receiving it in time. So basically, I think in terms of coordination, those are the issues that I've noticed in the Zambia response, and going forward, how we can continue improving the response effort for COVID and other responses. Thank you.
Ngoni, thank you so much. There's so much learning from Zambia. I really appreciate all those thoughts that you've shared with us. We're going to come back to you later with questions, I'm sure. I'm just going to go to our final panelist, Diana Madar, who is currently the Risk Communications Lead with the UK Emergency Medical Team in Beirut. Diana has led projects on virtual exchange programs, women empowerment, youth engagement, democracy and citizenship programs, and presented leadership workshops in London, Peru, Spain, India, Bulgaria, USA, and Thailand. So Diana, over to you, please, for your opening statement. Thank you.
Thank you first for inviting me. And I would like to give you an overview about the Lebanese context, and then moving into our role as RCCE, our challenges and success stories. So on August 4th, two huge explosions in the Lebanese port have killed more than 200 people and injured 6,000, with over 100 still missed. The cost of damage is huge at all the levels, financially, politically, socially, as well as at the health sector. On the top of that, we have COVID-19 pandemic. Lebanon hosts more than 1.5 million refugees and 250,000 migrant workers. The majority is not working. They are unemployed now. The Lebanese currency lira has lost more than 80% of its values. All these put this country in a very critical situation. So, this communication and community engagement, RCCE, is a part of the work that UKEMT is doing in Lebanon. And a lot of people are asking, why RCCE in the midst of all these things? But our role is really essential in designing a primary prevention framework that is needed to prevent hospitalization and to mitigate the burden of disease at different levels. Therefore, RCCE role is crucial to engage everyone through a participatory approach in spreading awareness and protecting the well-being of community members. Now the number of COVID-19 is increasing. We have more than 1,000 to 1,500 cases every day. And the healthcare system is suffering, not only from shortage in human resources, but also from equipment, supplies, financial things. So we need, our role is very essential actually to push people to take the precautionary measures to survive, to save their lives, and to avoid more burdens on themselves as well as on the healthcare system. However, we're facing a lot of challenges related to people's misconceptions, fears, lack of trust, lack of education, a lot of resistance. A lot of people are saying, we need to earn money, we need to survive. we will die from starvation and not from COVID. So we're facing a lot of resistance, not only at the community level, but also at the hospitals, in the hospital settings. But as RCCE UK EMT, we're able to overcome a lot of the challenges through the first key of a successful project is building a trust. So building a trust among community members and playing the role of mediator between different entities such as hospital and NGOs, hospital and municipalities was very essential in order to overcome different challenges. Also, another success story is related to the multidisciplinary approach that we were using in order to be able to connect with lay people, with key leaders, with sheikh, priests, local NGOs, and the most important thing that we were working towards achieving SDG number 17 in the UN 2030 agenda, which is a partnership. Partnering with international organization also is a second key for any successful project. So in this work, we were able not only to engage those local partners in our work, but also to empower them to be able to continue with this project, to maintain the sustainability of those projects. So we work to increase the number of health ambassadors in our communities also. So everyone should feel responsible to care and to spread awareness. Everyone should be an ambassador to spread the right messages. Honestly, I can see that within the next 10 years, we will witness the creation of a new socio-ecological framework that's based on solidarity. Since we are able to achieve great results and outcomes at the short level, I'm sure that we can work on a solid and comprehensive plan in order to be able to build a new generation who work very hard on preparedness plan and who is ready to respond to any outbreak. So, in my opinion, this plan required and like continuous capacity building for the influencers. We have a lot of influencers in our communities, and we should use them. So we need to build their capacities in the communities, and that's why the role of EMT is very essential, in my opinion. There's a huge gap in matching between partners and influencers in order to lead their communities. Innovation and the creativity also should start from somewhere, and we need this EMT in order to be the mediator, to connect the dots, to build a strong partnership, and to provide local partners with a solid platform to start from. So finally, I hope that our new generation can rely on data and best practices to influence decision makers at the national level and to be a country with free corruption. And we need the new generation for the betterment of our country. And in Lebanon, I know that everything is very hard to achieve, but I believe that if we educate a new generation, we empower them, we will be able to overcome all these challenges at different levels. Otherwise, we will be repeating the mistakes again and again. Thank you.
Thank you so much, Diana. I'm very happy to hear the view from Lebanon. So thank you very much. I'm sure there'll be many questions for you. So we've finished with the opening statements of our panelists. So now we're going to go to the question answer, and I can see there's quite a few questions in the chat. I'm going to pick some of the questions and then direct them to the most appropriate panelist. So the first question that I'm going to pick is first to Professor David Heymann. So it's a question from Asama Hassan, and they're saying, how can we ensure building a proper national capacity whilst most low and middle income countries suffer from political and social conflicts, instabilities or corruption? So over to you, David.
Good question. And the answer is that groups like UK Med are very important in the solution. The solution is that health is always considered an excellent tool with which to negotiate. And so in a government that's dysfunctional or a government that's divided, to get the parties together and to talk about issues in health with a neutral mediator, such as someone who might come from UK Med or somewhere else, is very useful. I can give you some examples. In Afghanistan, it was very difficult to reach populations during polio eradication because there was suspicion of the eradicators. So there was a negotiation done by a neutral body. It wasn't UK Med, it was the Federation of Red Cross and Red Crescent Societies. And their negotiation was such that the Taliban agreed that polio workers could come into their areas if they had no mobile phone and if they weren't with transport. So if they were on foot and came in, they could deliver the health goods. This type of solution is very important. Rotary does it all the time, and many other groups, in trying to bring together the dysfunctional groups or the combating groups within a government, using health as the negotiating tool. So the answer is negotiate with health, and then with that negotiation, begin to strengthen the infrastructure that's necessary.
Great, thank you, David. So the next question I'm going to ask is from Rosanna Glazik. I'm sorry if I pronounce any of these names wrong. So it's, what lessons can we take from the pandemic to improve global North-South collaboration in outbreak response? And I think I'm going to ask Emilio to come in on that because of the remote support that you were talking about. So over to you first.
Thank you for the question. I think only speaking from my own side, the relationship that we've been developing with colleagues in Africa CDC has been really collaborative and very much a partnership, and that's been a really great experience to be a part of and to see that evolving. And I think those longer term partnerships where we're engaging with each other and learning from each other are going to be really the key to maintaining healthy relationships going forward. And I think it's been a really two-way experience for us working through this together. So yes, I think that maintaining links and having sort of longer term partnerships is key to improving our understanding of each other and of local priorities in various places. So I think that's my perspective, but I think it would be great to hear other people's as well.
Thanks, Emilio. I will ask actually David Heymann just to comment on what Emilio said, seeing as you have more of a kind of global oversight. Do you have anything to add on that question?
No, I think Emilio is absolutely right. These relationships that are being formed now virtually can continue after this outbreak is over or after other outbreaks are over, and fill that gap that usually occurs when the donors don't want to provide funding for staying after an outbreak or a situation. They only want you there during the time. So working virtually is, as Emilio says, is a superb way of continuing that collaboration and helping transfer skills into capacity strengthening through agencies like the Africa CDC. So I think Emilio is right on target on that.
Thanks. And just following on from that, there's a very interesting question in the chat box, which I was actually going to ask, and it relates to your opening statement, David, but I actually wanted yourself, Ngoni and Emilio to answer it. But it's from Daniel Grace, and it says, do you think that many African countries have responded better to COVID due to their previous experiences with Ebola and similar health issues? So I'm going to go to Ngoni first, seeing as he is in Zambia at the moment. So Ngoni, would you mind answering that question?
Okay, thank you very much. I think in terms of preparedness, most of the African countries, they tried their best, but considering also that it was an emergency, a global emergency, resources were constrained to the extent that whilst preparedness mechanisms were put in place, it was now in terms of the access to resources, receiving of essential supplies, taking a bit of time. So it could be done better because Africa received or had their positive cases a bit later than other countries, of which there could have been better planning and ensuring that they are also equipping themselves, and be it frontline responders or awareness to the communities and everything. It could have been done better. The African context, the COVID-19 reached it a bit later compared to other, but resource constrained. Most of the countries, they couldn't really do much, and they were actually working with local strategies in terms of making sure they respond well with shoestring budgets. So a lot could have been done, but it was very resource constrained. Thank you.
Thanks, Ngoni. I would go to Emilio just to complement that.
Thank you, Ngoni, for your perspective. I think it sounds like you're being quite harsh, because I think from all of the interactions that I've had with colleagues, actually, with all of those constraints, there's been a real drive, and never have I heard any sort of complacency that this pandemic has been respected a great deal by all of my colleagues working in African countries. And I think sometimes that maybe hasn't been as strong in other countries. I think, yes, the resources issue is huge, but with those limitations, I think some fantastic work has been done, and there's been a huge amount of energy being put into the response at an early stage, as Ngoni was saying. So that's just a point to add, that I think, yeah, the respect has been huge, and the pandemic response has been given a very high priority.
Thanks, Emilio. David?
Yeah, I think Ngoni's also been very hard on his compatriots, because Africa has really shown the way in many things. And one of the ways that Africa has shown the rest of the world what needs to be done is the way that they've been able to develop their skills in working at the community level, because communities are very, very important in all this. And I remember working on several Ebola outbreaks in the past with Professor Moyembe from DRC. When he goes to an outbreak of Ebola, and I've gone to many with him, he doesn't go to the hospital first, he goes to the district commissioner first. And he says, call together the village chiefs, I want to see them. And he speaks with them that evening, the first evening, telling them in their own language what is happening in the outbreak and how important it is that communities be at the response base and that they work with the international teams. It would be great if this learning, which Africans have and which they apply, could be moved up into Europe, into countries where governments are still trying to do many things centrally and not depending on local capacities. So I think Africa has innate skills in dealing with disease and with other issues that they've dealt with in a traditional way for many times in the past, and are continuing to do that with this current COVID pandemic.
Great, thank you, everyone. I want to talk a little bit about risk communication, community engagement, and trust. And I think this has been a pandemic theme and very different across many different countries. There's a couple of questions in the chat related to how do we combat misinformation. Ryan is asking about the new social ecological model based on solidarity that you mentioned, Diana. And then Marcel is also saying, how do we kind of ensure that RCCE is not overlooked? So there's a lot in there, but I think that you can answer that very well. So just over to you.
Yeah, sure. Yeah, actually, these questions are very, very interesting. I'll start with the framework itself. So when I mentioned solidarity, because, you know, the role of, that's why I stressed on the point of partnerships, because, you know, when we have like weak state, we need to, we will have the international organization and NGOs as backbones for the community. So that's why when I'm talking about solidarity, I mean having like partnering with international organization, with WHO, with the local NGOs, with local communities, in order to make sure that we're following the right strategies in order to tackle all these layers of the ecological model, starting from the individual himself, moving towards the community, and then putting policies at the national level in order to be able to eradicate all the misconceptions and weak work and things related to any new outbreak maybe. So this is the main point out of solidarity in having it embedded in a new socio-ecological model. For example, I want to give you an example that might answer also the misconception question. So, for example, one of the success stories that happened to us is that we were working in a region in Saida in South Lebanon, and as a part of our work with UKEMT, and then we figured out that we have big part from this region are refugees living in a very crowded area in Ain al-Hilwi camp. It's a camp for Palestinian and Syrian refugees, and a lot of people like Lebanese who cannot afford living in dignity, let's say, they go and they search for their small houses or tents in that area. So this area needs a lot of attention, and definitely we need to empower those people there. So we decided to do, like, for example, training TOT for the CBOs, the community-based organization, and the NGOs who are that they are working in this area. So because those people are in direct contact with beneficiaries, so we were able to make like workshops for 2 days with more than 45 NGOs that are working with refugees in order to provide them with the information. And unfortunately, what we found was very, very interesting is that those NGOs that are dealing with those people in the refugees, and they told us that they are doing a lot of awareness campaigns regarding COVID-19, themselves they have misconceptions, a lot of misinformation about COVID-19. So this session showed like we did like some basic statistical analysis, and we figured out that the knowledge curve like was increasing in a very, very interesting way, to show us that these sessions and this RCCE is very essential in order to build the capacity of those people and to spread it among other community members.
Thanks, Diana.
Do you have a further question, or that's it? I didn't.
I think that was an incredibly insightful overview. I think I'm just going to go to the next question. We've got a lot coming in now, but we'll probably come back to some of the community engagement side. Sorry, on mute there. There's an interesting question from Cam Khan, and it relates to kind of how do we fund all of this? We know what we want to do and what needs to happen. And he's or she's written, what threats are likely to come from the increasingly inward-looking policies from many wealthy nations, which are likely to be made worse by the financial pressures of the global pandemic? And are there any opportunities to change the way aid is delivered globally? So I think this is something that's been on many of our minds. I'm going to go to David first, but I'd actually like all the panelists to kind of give their kind of 1 to 2 sentences on what they think should happen with funding, and how do we ensure that we have funding to continue international response. So I'll start with you, David, and then we can work through our panelists. Thank you.
Thanks, Sarah. I'll just try. I think there's a real structural issue in getting funding into capacity development and into preparedness. And that is that many donor agencies have a special envelope for response to outbreaks, and then a different one for capacity strengthening. And what needs to be done is those two need to be merged together so that the funding that goes into an outbreak is also able to stay in a country after an outbreak, so that groups like EMT can stay on, the EMTs and UK Med can stay on and can do the job of strengthening capacity so the next time there's better preparedness. So that structural change would make a big difference if development agencies could provide funding for preparedness before an outbreak rather than only providing funding to respond to an outbreak. And this includes ECHO in Europe and many other groups.
Great, thanks. I'll go to Emilio next.
Thank you. I think I'm going to make a fairly closely related comment, really, that yes, the sort of the narrow vertical programs that often are attached to responses mean that you've got quite a, I speak for infection control specifically, and in a lot of low middle income countries, the only sort of investment in IPC is in response to an ongoing outbreak, and there's no element of sustainability in those mission TORs. So you've often got a cadre of people who may be trained and very experienced in dealing with Ebola, for example, but they've not been able to work on ventilation. So COVID comes around and those skills and that experience isn't necessarily transferable, and there hasn't been an ongoing engagement. So yeah, I think a broader or a more open expectation of integrating sustainability into programs by donors would actually be better value for everyone involved, whether that's just purely from a financial perspective, but also from partners as well. That I think that would be a sensible and a forward-looking evolution over.
Thanks, Emilio. Ngoni, what are your thoughts on funding?
Okay, thank you. I think I would agree with Professor David in terms of making sure that strengthening local capacities is something that is very critical. But most importantly, also we want to also make use of the local knowledge systems to contextualize anything that is coming on board to suit the local context, which makes it very sustainable. And normally, if we make use of the local intelligence that is available, you actually realize that it can actually come being cost effective in the long term, both on the human resources and also in terms of the funding mechanism, because the moment we use local technologies, it actually improves in it actually helps a lot in terms of making sure we cut on budgets on sustainability and budgets of technical support that might be needed from outside. So I still stress the issue of the use of local technologies and local indigenous systems, whilst we focus on capacity building as a sustainable mechanism whenever there's an outbreak like this one. Thank you very much.
Thanks, Ngoni. And Diana, over to you.
Yeah, actually, I don't want to, I will second all the panelists here and specifically Dr. David. Also, I believe that also if we can start working on the education system, specifically in these areas that are affected by different factors, like in Lebanon, for example, if we start changing the curriculum, the educational curriculum itself, and to integrate a lot of concepts related to WASH, to IPC, to different things, starting now, we will be able maybe to overcome, or at least to stop spreading things and rumors about, because I guess, in my opinion, rumors came from lack of education and lack of knowledge, and it's a culture. So if we start like investing in our new generation, we'll be able to save our lives. So in this way, we can also save money and rely on ourselves.
Great. Thank you so much. We're now coming to the end, and I'm very sorry that we've not been able to get through all of your questions. We will try to answer them all after this this webinar. So I'd just like to say a huge thank you to all of our panelists. It's been really a pleasure to have you, and I wish I could keep speaking to you for much longer about all of this, and we never have enough time on these webinars. So I'd just like to bring the event to a close with a few final remarks and thoughts, and based on the discussions we've had tonight, but also of UK Med's activities and thoughts for its future. So I think, as we've heard this evening, continuation of care is vital in consideration. And I say this from working for an organisation that's worked a lot on response and emergency response. But I think more and more we've learned about funding needed to be available for preparedness and recovery, and also to be quite broad looking to look at things like risk communication, community engagement, and invest in capacity building before the emergency. We've seen a lot that outbreaks can impact on top of existing emergencies. And so this continuous programming and partnerships is extremely important. And we feel, I think, as an organisation and as a wider sector, that we have a role to take in speaking to stakeholders, and including donors, to understand this kind of importance balancing act and ensure that funding priorities do not solely focus on response, but preparedness and recovery. I think preparedness activities and building national capacity for outbreaks, complemented by the ability to contribute to surge capacity when health systems are overwhelmed, like we've seen in COVID-19. I think this investment in partnerships during peacetime ensure that these activities can be activated quickly, and this is what's needed in an emergency. And if these relationships are there beforehand, we have the chance to do that in a very timely way. So I think for me, there remains an important requirement for a significant standby capacity, and this can be in the form of equipment, specialists, remote support, partnership with academic institutions, and funding to be available in standby mode to be able to do this. And as a sector, I think we need to use our platform to ensure that donors and other players concentrate efforts and funding on preparedness, standby capacity, and recovery, as well as all of the other sectors that link into health response. So just a note on UK Med is that we've started the process for developing our next strategic plan that will take us from 2021 to 2026. And the discussion we've had tonight, I know, will feed into that process. And whatever your relationship with UK Med, we'd love the opportunity to continue that discussion with you. And we'll be reaching out with other ways to keep in touch. Great, so we've got 1 minute left, and I'd just like to say a big thank you again. Thank you to all of the panelists for spending time with us, and thank you to all of the participants and all of your questions, and apologies again we couldn't answer them all. Thank you very much for giving up your time. On behalf of UK Med, thank you and goodbye.